We'll kind of start by going over the cases a little bit more in depth while we're in here in this breakout session. So anyone wants to volunteer, Chris Valdez? I'll give multiple people minutes. Don't worry. So don't lay down just yet. sit facing that way for me. All right. So in the first case, we have Chris, who's a high school pitcher who just comes in with some pain going down the arms, numbness, tingling that's happening. Also some pain in the medial border of the scapula, right? Sometimes it can even be referred to that upper trap area, okay? Now, what I'm gonna do to examine him is to make sure where the pain propagation is coming from, right? So the first thing I'm gonna do, obviously, is make sure that there's no more sinister diagnoses, kind of check subjectively, make sure there's no fracture or anything like that. As I mentioned, this isn't a traumatic event, so I'm not thinking any fractures are occurring. But one thing that they'll typically come in with is they'll say that they have pain kind of right in here, right at the base of the neck. And then if you kind of poke on that area or try to mobilize that first rib, it's going to reproduce symptoms that go all the way down the arm, okay? The other thing I would do is look at his cervical range of motion. So I'm going to ask him kind of flex forward for me. Good. Any reproduction with that? If there is, then I might be thinking some like discogenic issues going on. So I'd want to further rule that out with any myotomal reflex changes, anything like that. And then I'll ask him to extend and see. A lot of times this is going to create some issues for them because they're closing down on their CT junction, which does not want to move. Typically, they're a little bit flexed forward. Chris actually has pretty flat back mid-thoracic spine, which we're starting to see a little bit more and more of now because a lot of their flexion is occurring at their CT junction area. I'll then ask them to rotate to the ipsilateral side, so rotate to the right. If that reproduces pain at that spot at the base of the neck, that is typically a clear for takeoff. We need to do some manips in that area to try to get that area moving a little bit better. And then side bending, of course, we're going to get that same reproduction, right? So any movements where we're kind of stressing that CT junction into some extension or closing it down a little bit, oftentimes they're going to have some issues. The other thing that I'm going to want to look at is how well do they flex? So can you kind of hunch over for me? And he actually comes out of that flat thoracic spine pretty well, still a little bit there. And then how well can he then extend, right? And one thing that you can try to have them do is, can you do an overhead squat for me? Just raise the arms up overhead. This is a really easy way to kind of clear it. He doesn't have a ton of issues getting that extension because he's already there, right? So Chris actually can probably do an overhead squat without any big issues. The other thing I'm going to want to look at is how well does he rotate? So can you put your hands behind your head for me? And then just try to rotate to your right. Good. And I'm looking for any limitations that might be caused through limitations in the thoracic spine. Okay. I'd have him do that to the left side as well. Now, typically, if they're a pitcher or a batter, if they're right-handed, they're going to be able to rotate more one way than the other because they do it all the time when they're swinging their bat or they're winding up for their pitch, right? So don't be alarmed if you see someone that has much, much more rotation to the right than they do to the left, okay? Golfers, this is a big issue as well. They can typically over-rotate to the right, but they can't rotate at all to the left, so then they might start having some left-sided issues there, okay, just from the stiffness that they've generated there, okay? So to perform the manipulation, I would have Chris lay down on his back, and I'm going to try to move this out of the way a little bit so I don't crush the microphone. We'll see if that works. All right, I'm then going to have him cross his arms. Now, I don't want him to cross them like this, right? I want his elbows stacked together so that when I lean over him, all my force is going through his elbows, okay? I'm going to create a kind of fist like that with my thumb up. The spinous process is going to go right in that little valley right there, okay? So, and typically I like to do a little bit of a tissue twist to try to lock it into place, okay? So I'm gonna start here and then wind to there, okay? Now, if we want to get technical, the area that I'm manipulating is actually the area right above where my top finger is, my index finger, okay? Because that's the area that's kind of gapping a little bit. So I'll wind up the tissues, I roll him over, and then I put my sternum through his elbows, and I provide a little bit of a kind of a wind-up force before I actually do the thrust manipulation, okay? So if I go real quick with it, comes here, I wind him up, roll him over, and then provide that little bit of a thrust manipulation. Now he's got that opioid release. He feels really great afterwards. So that is the thrust manipulation for the thoracic spine. You can then do it at multiple levels, right? Which is usually what I'll do. I'll start up top, and then I'll work my way down, okay? So I would start up here, roll him over, thrust, rewind up here. Now I'm gonna flex him a little bit more and add that thrust there. And then you can get all the way to the TL junction and do the thrust there, okay? Now usually on the first thrust, you're gonna get a bunch of cavitations. And then on the second and third thrust, you're gonna get fewer and fewer cavitations as you've gotten all those joints moving pretty well. Okay. Let me go ahead and show the CT manip real quick. So for the CT manipulation, we usually have them in prone, and I'm going to put them in a kind of mid-range movement. Okay. So I like to put a towel there just to keep them from over-rotating or over-side bending. Okay. Let's do your left side. So look to your left. And I'm going to place them just a little bit into rotation. And then I'm actually going to be side bending them. So I slacken the upper trap here. That's going to provide me that really nice, really low resistance to that side bending. Okay. I'm then going to come over the top of them. So this is one where you're going to need the table a little bit lower, which is why I've put the table pretty much all the way down. So in those athletic training room tables, you'll probably have to get some steps to kind of bolster yourself up a little bit, okay? I'm gonna put my thumb right at his CT junction. So I'm gonna come in from the side and try to approximate to his CT junction, okay? I'm then gonna take my hand over the top of the head, not at the back, because I don't want any additional rotation for him. You can go straight to the side, over the top, and then I'm gonna find his in range and then come out of it just a little bit. So I'm kind of playing with him just to kind of test the water, see how it feels. I'm going to check with him, see, all right, are you having any increase in symptoms with this? Are there any sharp pains or anything that I need to be aware of that might say, ooh, maybe I don't need to do this manipulation? As long as everything checks out, I'm then going to go to mid-range and then do the manip there, okay? So it's 60% with the shoulder hand, 40% with the head hand, okay? So I am manipulating with both hands on this one, okay? And then we could flip him over and do the other side, okay? Go ahead and come on up. All right. Another way to do this is to do a closing technique. So can I have another volunteer? Thanks, Chris. All right, come on over. All right, so for those that don't close very well, so Chris closed really well in his thoracic spine, so I didn't necessarily need to do anything that pushed him into closing for the thoracic spine any more than he already was, right? I needed to kind of flex him up and open him a little bit, which is what I did with the gapping techniques. For someone that's a little bit more kyphotic, I'm not saying that you are, but we want to promote a little bit more extension through the thoracic spine. The one way you can do it is to have them lay on your belly for me. All right, and then I would have them just turn their head to one side if they don't have a face hole that they can lay perfectly straight in, right? I'm then going to take my hands and kind of do this cross grip here. So my areas of pressure are going to be right on the TPs of the spine, okay? Preferably at the same level. I'm then going to take a little wind up here and then just provide that force down and then do a thrust from there, okay? Like that. And again, typically you're going to get multiple cavitations with this. It's a very quick technique. You'll load it and then provide a very low amplitude but high velocity thrust to get that cavitation. Okay? That feel okay?
Yeah.
All right, perfect. So then to follow that up, we would want to give them some thoracic mobility exercises, okay? So actually, would you mind doing a cat-camel for me? So for the cat-camel, we want to promote some of that motion that we just promoted with our manipulation, okay? So coming up, nice rounding of the thoracic spine, and then we go down and get that nice extension through there, okay? We can also do some quadruped rotation as well, especially for any rotational athletes, okay? Can I get a guy with a bigger chest? Yeah, I'm looking at you. So for the bigger individuals, he's much taller than me. It's going to be hard for me to manipulate him, right? Because I have to provide enough force to get through this, right? So can you go ahead and lay down on your back for me? Your other back. Don't worry, happens all the time. Okay, so if you cross your arms here, like that, so we stack the elbows. Now, if I try to get over him, it's just not going to work, right? We see this a lot with like linemen who are much bigger. It's really hard to provide that force and get up over the top. I've literally seen people try to like jump, right? That's not going to work, especially for shorter people. Chris is a shorter person, but he's able to do it all the time, right? Now, if you jump, you can probably get a manip, but there's another way that you can do it. So can you stand up for me? Is by having them lay over a foam roll. Would you mind laying down there? Hopefully this floor's relatively clean. All right, so you have them kind of lay over a foam roll and then place your hands behind your neck like this, okay? And then I'm going to step over them and then bring them up this way, okay? I'm then going to provide that force down, okay? And then do a little thrust there, okay? Now, it might take a couple of tries to get that force right over the foam roll, okay? This is a little bit harder technique to do, but with some practice, you can kind of gauge where he's getting that flexion through, and then you can do the manip through there, okay? Nice, thank you. All right. Any questions on any of that? Yes.
The cervical manip, the hand, is it more of like a down and in motion?
Good question. So yes, it is more of a down and in at a diagonal, okay? So your goal is that you are providing a gapping on the opposite side. So if I'm doing it this way, I'm opening up the left side, okay? Which is why you're technically treating the left side when you do it, okay? Let me show the talocrural manip and the cuboid manip, and then if anyone wants to practice, I can give some feedback on it, okay? Does anyone want to volunteer for the talocrural? You? All right. Oh, perfect, because you're wearing sandals. This works well. Let's go facing this way. So just have your feet hanging off the side. You can kind of stay in this long sitting position. If you can, remove your sandals for me. So for the lateral ankle sprain or chronic ankle instability, oftentimes we see that they are limited in dorsiflexion range of motion, right? So we're going to want to try to gain some dorsiflexion range of motion. he actually does have, especially on this side, a little bit of limited dorsiflexion, right? Not uncommon. We see this in almost all our athletes, unless they're just a hypermobile athlete. But for, let's see, I'll do this one. For the talocrural manip, you're essentially going to grab their foot as close to the talus as you can, okay, and provide this scoop here. And when you do that, you want to bring in your elbows, okay? You don't want to try to manip from here, because then it becomes just a chest kind of workout for you, right? You want to lock everything in nice and tight so that then you can use your body to do the manip, okay? So for him, I would lock it in here. I'm going to try to kind of scoop and dorsiflex him as I'm doing it, right? Because I'm trying to get to that physiological in range for him, or at least close to it. And then I'm going to go there and provide just that manip there, okay? That, okay? So a really easy one, really simple to do, highly effective for generating some dorsiflexion range of motion, okay? If they are complaining when you dorsiflex that they have pain in the front of the ankle, this is a go-to manip for them, because you can immediately clear out that anterior impingement with this manip, okay? Cool. Actually, since you don't have shoes on, stay here. For the cuboid manip, which I mentioned in the lecture, oftentimes they're going to have pain right over that cuboid, right? So let's say they sprain their ankle. That cuboid is going to plantar flex a little bit. And if it stays plantar flexed, whenever they put weight through that cuboid on that bottom side, they're going to have a lot of pain, right? Oftentimes, like I said, feels like there's a rock in their shoe, or they're stepping on an acorn or something like that. Acorn? Acorn? Acorn, depending on what part of Texas you're in. So to assess it, all you're going to do is kind of squeeze it and try to move it around, okay? If it's painful, that's a pretty good indicator that the cuboid is involved, right? Especially if it's just pain to palpation and movement, okay? So to do the manip, you would have them flip over. And then one thing you can do, if you're uncomfortable with the manip, is literally just try to squeeze it. They call this the cuboid squeeze, right? So you're going to squeeze it, and your force will be a little bit lateral with it, okay? So you're going to kind of take both thumbs, thumb over thumb grip is really good, and then plantar flex them just a little bit and squeeze it, trying to force it dorsally, okay? You can then add the manip to it by doing a little thrust there, okay? And if you get a cavitation with this, oftentimes this one does not cavitate. You get a cavitation with this, you know you just made some big changes, because every time I've gotten a cavitation with this, they have immediate reduction in their symptoms, typically 90–95% gone with their pain, right? And then you follow it up with a bunch of proprioceptive exercises, okay? Cool, thank you. All right, how am I doing on time? 3 minutes? All right, so Kevin, can you come here for a second? So everyone saw Kevin speak. Really nice talk, by the way. Would anyone like to try to manipulate Kevin? You're the worst. We'll do a thoracic manip, okay? All right. So this will be good for y'all to see some like tips and tricks and some feedback that Kevin and I can give to perform this manipulation, okay? So you want to start with arms across. Make sure that you didn't get the stretch, man. Make sure that their elbows are as close to being stacked as possible, okay? You'll then want to roll them over and then kind of get this grip here. You want to find a spine and then kind of get a fist grip there. There, and then kind of rotate to where you're in the trough of the spine. There.
And then down?
Yep, and then flex him down. But you want to load him first and then drop your weight. Okay? And this is where it takes a lot of practice, right? So you're seeing what most of y'all will look like once y'all do it the first couple times, right? Her thrust is not very quick. So the quicker the thrust, the better, right? You also need to load first and then provide the thrust, right? Because if we're not getting to that in range, then most likely we're not going to get a cavitation, right? Oh, so good question. So you want to try to load their tissues up. You want to try to take them to their physiological in range before you provide that extra little bump to get them past that in range. That's what causes the cavitation, the pop. That's when they start getting a little bit more benefit from it, right? Yes. All right. One more, and then we'll rotate. So this takes a lot of practice, right? Yeah, so she's a little bit shorter. She's going to lose some force by being up on her toes, right? So, nice. Not bad for your first time.
Thank you.
All right.
Everybody back across, out the hallway, go straight across.